Welcome and thank you for joining us for tonight's update in partnership with St George Hospital. My name is Bertha at Central and Eastern Sydney PHN. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise a continuing connection to land, water and community and pay respects to elders past, present and emerging. I would also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. A couple of events which may be of interest to you. You can find these by visiting our website or scanning the QR code. We have one final remaining cultural awareness training, which will be held at Karela Golf Club in November. And we have 2 CPR training sessions left for the remainder of the year. One of them is 13th of October at the Cesspin office in Mascot and November at Tradies Gymea. And lastly, we have the nominations for the Primary Health Awards, which will be closing on the 31st of August. Please visit our website or scan the QR code for more information. I would now like to hand over to our GP facilitator tonight, Dr. Martina Gleeson, who is a local GP and the clinical lead of South Eastern Sydney Health Pathways. Thank you, Martina.
Thanks, Bertha. I'd like to introduce Sundra Ramanathan, who's a senior staff specialist haematologist at St George and Sutherland Hospital. I'm sure many of us have had dealings with Sundra if we've had any patients who've needed his haematology support. And Sundra's going to speak to us about just a brief overview of myeloma in Australia in 2025, what the new therapies might be and what might be coming and how we can think about it and recognise it, hopefully. So thank you, Sundra. I'll hand over to you and then please put the questions in the Q&A box and I'll pass them on to Sundra when he's finished his talk.
Okay, thank you for inviting me to give you a talk. So I'm just going to do a brief overview about myeloma in general, particularly what's happening in Australia in 2025. The field of myeloma has evolved significantly over the last 25 years in particular, after a long time with not a lot of change. There are a whole slew of new drugs that are out there. Not all of them are available in Australia, and so that makes it a bit complicated when we're trying to discuss treatment options with patients, because they may have heard about various things that are available, and sometimes these drugs are not necessarily available on the PBS. So, down. What's that working? Oops, technical issue. I need my page to work. Let's see. Okay, let's try that again. So, I'm going to talk about plasma cell disorders. On the right is the new WHO tumor classification for hematological malignancies. It's now in 2 parts. Having when I first had the first copy of this book, it was one book. It's getting bigger all the time. In the section under plasma cell disorders, there are a whole range of plasma cell disorders. Some are extraordinarily rare. What I'm going to talk about mainly today is non-IgM monoclonal gammopathy of uncertain significance and plasma cell myeloma or multiple myeloma. I'm not going to talk about plasmacytomas and what's increasingly been called monoclonal gammopathy with clinical significance, because that gets very technical and a bit getting into the bit of the weeds of things. So we'll just focus on these things. So the first thing is there is an evolution to multiple myeloma. We start off with monoclonal gammopathy of uncertain significance, which may evolve through a phase which is called smouldering myeloma before it becomes multiple myeloma. When we're talking to patients with MGUS, we quote that there's a transformation rate to myeloma, lymphoma, or amyloid of about 1 to 2% per year. This is very old data from Olmsted County in Minnesota, where the Mayo Clinic's based, and that was a large population study that goes back many years now. But on average, that's the figure that we use. In recent meetings that I attended, which was the EHA Congress in 2025, which I attended online, there's a lot of stuff about the biology of myeloma and how things are evolving. And using some very sophisticated genomic and genetic testing, It's believed that the first clonal cells that cause myeloma are probably in the bone marrow in the second or third decade of life. Now, the median age of onset of myeloma is probably around about 65. So there's about a 30-year latency before you progress from this clonal plasma cell in the bone marrow to fulminant myeloma. These studies also looked at what happens in the tumor microenvironment, so that's the bone marrow. And it's thought that what happens is there is persistent immune stimulation of the environment caused by this malignant clone, which results in eventual T cell fatigue and loss of immune control. And as a result of this, the malignant clone can then evolve and acquire mutations. So this, in part, has moved towards treating things like smouldering myeloma earlier. And it's possible that if you initiate therapy earlier, particularly with immunotherapy, when the T cells are healthier, potentially myeloma becomes curable. The difficulty here, as I see it, is that smouldering myeloma is classified in a particular way. I'll come to that in a second. And it's just a question of, are we really changing things, or are we just calling it myeloma and saying you meet indications to treat earlier? And there's a case that might be what we're doing, and maybe we should just call it myeloma and just treat it. The problem is there's a long prodrome, and a lot of people will not need therapy at that point in time. So unless you're looking at something that is curative, the question is, am I exposing someone to toxicity unnecessarily before they need to be exposed to that toxicity? So when we talk about monoclonal gammopathy of uncertain significance, this is the diagnostic criteria that we use. So we're talking about a monoclonal protein of less than 30 grams per liter, non-IgM, a clonal bone marrow population of less than 10%, and the absence of end organ damage. So this is in some ways where myeloma is different from other tumors. So in other tumors, for example, a skin cancer or a breast cancer or bowel cancer or whatever, your pathologist will look at you and say, these cells are malignant and they're confined to the organ in question, the skin or the breast or the bowel or whatever, or it's spread beyond the margins. In myeloma, we're looking at whether there is peripheral tumor end organ damage. So that's somewhat unusual compared to how other malignancies are defined. Light chain monoclonal gammopathy. So when I first started training, we couldn't recognize this entity because we weren't able to measure light chains. We can now, and so we measure the kappa lambda in the serum, and we look at the ratio. So if you can't find immunoglobulin heavy chain, but there is an elevated kappa lambda ratio, possibly there's light chain MGUS. Again, there has to be no evidence of end organ damage, and clonal bone marrows of plasma cells of less than 10%. That being said, I don't do a bone marrow on everyone because I'll be doing lots of bone marrows on people with very small paraproteins and light chains. So we do a sort of risk assessment and say, I think this person probably should have a bone marrow, or this person can watch and wait, and we'll just monitor them. Smouldering myeloma is defined as an IgG or IgA paraprotein of more than 30 grams per litre. Some of the older classifications used 20 grams for the IgA. You can have urinary monoclonal proteins of greater than 500 milligrams in 24 hours and or clonal bone marrow plasma cells between 10 and 60%. If it's above 60%, it's classified as myeloma. And again, the absence of myeloma defining events or amyloidosis. Myeloma itself requires a definition of more than 10%, greater than or equal to 10% plasma cells in the bone marrow, or a biopsy-proven extramedullary plasmacytoma. Then we talk about the CRAB criteria. So the presence of one or more of hypocalcemia, renal insufficiency, anemia, or a bone lesion. The bone lesion has become easier to recognize with more sensitive testing. And it's a question of what test you've got access to. So again, when I first started training, we did plain x-rays, which were very insensitive to look for the presence of lytic lesions. We now do CT skeletal survey, which is pretty good. There's also the option to do a PET CT. Now, PET CT's now got an MGUS rebate for multiple myeloma. I think you can do it once per lifetime or something, but sometimes we do it a little bit more, and it's good. And it's a reasonably good way of identifying lytic lesions. In more recent times, people are talking about what are called the SLIM criteria. So this is clonal plasma cells in the bone marrow above 60%, or raised free light chain. So in this case, the light chain ratio of involved and uninvolved light chain over 100, with the involved light chain being over 100 as well. And more than one focal lesion measuring more than 5 millimeters on MRI. That's a bit more difficult for us to get. Getting a whole body MRI is difficult. It's not funded. So that can be an issue. I've recently done a MRI of spine and pelvis for someone who's got high paraprotein and looks like a smouldering, to try and prove that he's got symptomatic disease, meets the SLIM criteria, so I can enroll him onto a clinical trial. But unfortunately, he didn't meet the criteria, I don't think. So that was a bit disappointing. In terms of myeloma epidemiology, so this is from Cancer Australia. The standardized age incidence is about 7.6 per 100,000, slight male preponderance. And the 5-year survival data has improved. So 1989 to 1993, the 5-year survival for myeloma was 28%. 2014 to 2018, it's 55%. And in some parts of the world now, it is significantly better than that, given new therapies. As I said, the MGUS evolution data came from Olmsted County in the US. More recently, this study was done in Iceland, which was an amazing study. They offered myeloma screening to the entire population who were over 40 at the time. So it was done in 2015. So everyone born 1975 or earlier were offered, and they managed to get half the population that was eligible screened. And they've got this website which has got some nice calculators which you can play with to estimate risk of progression and things like that. And the interesting things were, they found that the MGUS rate does increase with age. Got a better picture there. The rate of MGUS increases with age, both males and females. There's a gap between them which stays. Curiously, IgA MGUS doesn't seem to increase with age, and I don't know why that is. And roughly, the crude prevalence of MGUS in this population was about 4.5%, and smouldering myeloma much less, 0.53%. I don't think this data had what the rate of transformation from MGUS to myeloma was. So how do we suspect myeloma? The problem is there's no characteristic presentation for myeloma, and by and large, it's not detected on our routine investigation. So it's not like, for example, finding someone has anemia with microcytosis, which you might say, okay, this person we're thinking might have iron deficiency anemia. It doesn't show up in that way. And again, one of the problems is myeloma is often asymptomatic until a catastrophic event occurs. So some of the presentations that have come to me from primary care type settings are people who've come along with anemia, bone pain, fatigue, neuropathy. So often these patients have been investigated for these things or been sent for review with regards to these things, and a paraprotein has been identified, and in the workup, myeloma has been diagnosed. We also see people who have renal impairment, hypercalcemia, though that's less common coming from the primary care setting. And sometimes people are being worked up either by their GPs or by their endocrinologists for early onset osteoporosis. Sometimes they've had a liver function test, and as part of the liver function test, it's been noticed that there's a large gap between the total protein and the albumin. So this is called the globulin gap. Some pathology places do report the globulin gap, and that basically represents the gamma globulin fraction where immunoglobulins live in the plasma, and that may represent a paraprotein. And I've had a couple of people come across to me who were blood or plasma donors, and a paraprotein was identified through their lifeblood donations, and then they were sent along for review. In terms of emergency department presentations, these are the ones who present with some form of catastrophe. So it's often a pathological fracture. Sometimes it's a minimal trauma fracture. We've had someone have a fracture of their humerus when they're pushing up through a chair to get out of a chair. Sometimes people come with back pain or incipient cord compression. Hypercalcemia causing confusion or weakness. And sometimes acute kidney injury. And sometimes these people present with edema and oliguria, anuria, sometimes hypertension, and obviously that's a very serious presentation which requires fairly urgent therapy. And some of these people will go on to need dialysis, but if we can treat them earlier, some of the kidney injury is reversible, and so they may not be committed to lifelong dialysis. So if we're thinking myeloma, these are the basic investigations that we do. We do the full blood count, the biochemistry. Now, that's not going to diagnose myeloma, but it will help us in terms of where we're sitting with the CRAB criteria. Then we do immunofixation and electrophoretrogram, and I'll show you a couple of pictures of those, and that identifies the paraprotein in the serum. We also measure the serum free light chain, and we do a 24-hour urine collection. It's not helpful to do a spot urine because particularly in hospitalized patients, they often have a Bence-Jones protein that's positive. So it's more useful to do a 24-hour protein, which tells us, one, how much total protein's been excreted and how much is Bence-Jones protein. If you're seeing mainly albumin, then you're worried about things like amyloid in the right setting. Whereas if it's a high Bence-Jones protein, even if people aren't meeting other CRAB criteria, there is a risk that they will develop cast nephropathy and go into renal failure. And sometimes that can be an indication to treat people for myeloma, even if they don't meet all the other criteria. We do a CT skeletal survey looking for lytic lesions because that's probably the easiest thing to access. And then depending on the circumstances, we'll then proceed to a bone marrow biopsy. So as I said, not everyone with a paraprotein scores a bone marrow biopsy. If their paraprotein is sort of in that mid-range of 10 to 20 grams per litre, and they're otherwise pretty well, I'll often do these other investigations. And if everything's stable, hold off on the bone marrow biopsy. If the paraprotein's less than 10, I usually won't do a bone marrow biopsy at all. And usually if it's above 20, we'll usually do a bone marrow biopsy looking for these things, but sometimes it can be deferred depending on our risk assessment. And we have some calculators on that iStop-MM, which can help quantify that risk. So this is what an immunoglobulin looks like. So it's this Y-shaped structure. It comprises of 2 heavy chains and 2 light chains. The heavy chain, which is the bit down here at the bottom, is what determines the immunoglobulin subtype. So whether it's an IgG, IgM, IgA. And this bit up here, the Y bit, is what determines what the immunoglobulin binds to. So it's where the antigen specificity of the immunoglobulin structure comes from. Now, when we look for a paraprotein, the protein is run on a gel with an electric current passing through it. And we see a gel that looks like this. This is then translated using a density analysis to work out what the spikes are. So the biggest spike is always usually albumin. Then we have alpha-1, beta-1, beta-2 globulins. And over here we have the gamma globulins. And this is where we'll identify paraprotein. With the immunofixation, markers are used to identify what this paraprotein is. And in this case, it binds the heavy chain of IgG, so it's an IgG type, and the light chain that's being bound is kappa, so it's an IgG kappa immunoglobulin. Now, these are some patient results that we sometimes see coming across. So this is the albumin, this is the gamma globulin. These two little blue ticks represent the area that's being measured for the gamma globulin, and in this case, this person had a 16-gram paraprotein. I cut off the bottom bit, but I think it was an IgG. And this one is 27 grams, and it's a IgM in this case. But this is what a electrophoretogram looks like with the density. Normal gamma globulin should look more like a speed hump rather than a mountain there. So the question is, who do we treat and when do we treat them? So one of the questions is myeloma incurable? At the recent meeting, there's a lot of discussion about this, and possibly with the right therapy, we can achieve what's at least a functional cure. I don't have access to those therapies in Australia as yet, but I'll come to that in a second. So at the moment, my discussion with most people is myeloma is still an incurable condition. It is manageable. And a lot of what we discussed then is what is the toxicity of therapy and what's required to initiate therapy and what does that therapy look like. And then part of the assessment is what is the likelihood someone is going to progress to end organ damage. So one of the arguments is with the slim crab criteria, particularly the crab criteria, is you're waiting for something bad to happen before you treat someone for their myeloma. And that's a fair enough assessment, but the difficulty is there are some people with high paraproteins who are not going to progress for very long periods of time. And you do run the risk of exposing them to some form of therapy that is unnecessary at that point in time. So what's the current treatment paradigm for a newly diagnosed patient? So at the moment, our main decision is this person eligible for a transplant or not? And we're talking about an autologous stem cell transplant using high-dose melphalan. Now, this is a therapy that was been standard of care for myeloma since the mid-1990s. And even in the era of all the novel therapies, it remains the backbone of therapy. Numerous studies have been done, and it shows that if you have a transplant, your progression-free and overall survival is still better. But the transplant's not free. It involves giving very high dose of chemotherapy, which will cause neutropenia, gut toxicity, and a whole range of other symptoms with febrile neutropenia and infection. There is a mortality of around about 2% from that procedure. And on average, I tell people it'll take about 3 months for them to recover from a transplant if everything goes well with no major complications or drama. So it doesn't look like much. We give the melphalan, which goes in a bag and goes in over 15 minutes, and then the stem cells go in the next day again over about 5 minutes. But in terms of the effect on the patient, I think it's probably similar to someone having a coronary artery bypass graft in terms of the time it takes to get over it and get back to normal. For people who are transplant ineligible, it's less of an issue now because our treatment is the same. Previously, the treatment for transplant ineligible patients might have been different, assuming that we weren't going to go on and do high-dose chemotherapy, but the induction treatments now are the same. So it probably doesn't make a lot of difference. It's just about planning about whether you're going to transplant this person or whether you need to collect stem cells from them. So what are the myeloma drugs that we've got? So there are a few different classes of drugs that are available on the PBS. There's the monoclonal antibody daratumumab. This is an effective myeloma agent. It targets CD38. So some of you may have heard of rituximab targets CD20. Has been around for 20 plus years to treat lymphomas, but this targets CD38. Ideally, I'd like to use it frontline, but at the moment I can't because of the PBS rules. The next class of drugs are what are called proteasome inhibitors. So the proteasome is an organelle within the cell which degrades proteins, and if that is blocked, these abnormal proteins accumulate in the cell and cause cell death. So the one that we use frontline is bortezomib. Carfilzomib is another one, but carfilzomib is not available for frontline use. It's only available in the relapse refractory setting. The next class of drugs are what are called IMiDs, or immunomodulatory agents. The first one was thalidomide, which was quite active for myeloma. It has some significant toxicities in terms of causing some somnolence and neuropathy, particularly when we first started using it at very high doses, but it does work. It's got two descendants, lenalidomide and pomalidomide. Again, lenalidomide is available up front, so that is our go-to drug. There's a risk management program for the IMiDs because they do cause birth defects. So there's a program that people have to sign up for, and we need to discuss with them about contraception and all of those sorts of things to minimize that risk. And then there's another drug called selinexor, which is called a selective nuclear export inhibitor. This is available, I think, after second-line therapy. It's a tablet and it can be used in combination with bortezomib or with dexamethasone, but it's a difficult drug to use because it does have quite a lot of gastrointestinal toxicity, particularly nausea. So it's a bit harder for us to use for most people. Now, there's a little chart which I managed to find about when drugs were approved in Australia. So thalidomide back in 2006 and lenalidomide for upfront in 2017. Now, the issue going forward is what combinations can I use? So while drugs are available on the PBS, I can't use them in any combination that I would like. So standard of care for many years in Australia was a triplet therapy with bortezomib, cyclophosphamide, and dex. That was available to us from 2012. Since from June 2020, we're able to use bortezomib, lenalidomide, and dex, which would be considered a standard of care triplet and had been for quite some time around the world before us having access to it. And coming up soon for transplant ineligible patients, will have access to daratumumab, lenalidomide, and dex. So that might change our assessment when we're looking at patients who are transplant ineligible, particularly older people, because bortezomib has a certain amount of neuropathy, and this might be a better combination. Worldwide, standard of care for myeloma is to use what's called a quadruplet therapy. So that's daratumumab or something similar, lenalidomide or something similar, with bortezomib or an equivalent, and dexamethasone. Unfortunately, I don't have access to that in Australia. Coming back to daratumumab, in Australia, it's only available on the PBS in the second line. So people who've had their transplant or their initial bortezomib, lenalidomide, dex who have progressed, they can then have daratumumab in conjunction with bortezomib and dex in the second line setting, but that is the only time I can use it. So it's a bit difficult for people who've had third or fourth line therapy prior to daratumumab being available, because I can't access daratumumab, and this then creates a problem when we're trying to enroll people in clinical trials, because most of the clinical trials are multinational studies, and in Europe and America, most patients will have had exposure to daratumumab already. So that makes it hard to get some people on trials. As I said, carfilzomib is not available first line. And lenalidomide maintenance therapy, which is used after an autologous transplant, we've been able to do that since April 2020. Supportive care. So myeloma causes lots of problems. The main issue is bone health. So we put people on bisphosphonates. We usually use zoledronic acid, and as opposed to the osteoporosis dose, we use a lot. So the first year we use monthly for 12 months, and then usually 3 monthly for the next 12 months. And that's usually sufficient from the first line setting. Depending on circumstances, we may reinitiate it at times of relapse. Bisphosphonates can cause osteonecrosis of the jaw, so we need to get a dental check before we start, and ideally, if there's any dental work that needs to be done, teeth removed or whatever, we prefer it to be done and finished before we start the bisphosphonate. We can get around it if someone has an emergency, but it's preferable to avoid the problem in the first place. We put people on valacyclovir to reduce the risk of shingles. Bortezomib and steroids in particular have a high rate of reactivation. Respirum Fort for PJP prophylaxis, and less of an issue probably with the bortezomib lenalidomide combination, but certainly lenalidomide plus dex has a rate of causing venous thromboembolism. So again, we do a risk assessment, and people are either put on aspirin or possibly a low-dose DOAC as thromboprophylaxis. People may become hypogammaglobulinemic with increased risk of infection, so we give them intravenous immunoglobulin if it's indicated, and we try and get everyone to be vaccinated for flu and COVID and other age-appropriate vaccinations, which we usually ask their primary care doctors to do. We acknowledge that on treatment, vaccination may not be as effective, but it certainly gives some protection, and it's better than nothing. Beyond the second line, there are a few combinations that are available. There's pomalidomide with various combinations, carfilzomib. There was a drug called elotuzumab, which we could use with len and dex, but that has been come off the market. I'm not sure why. I think that was a commercial decision. So we're not able to use elotuzumab up front, in that setting anymore. Patients who are still on it still can access it. We can't use it anymore. Selinexor, as I mentioned, thalidomide, very rarely used now, but there are some protocols that use it. And then we have the old-fashioned cytotoxics, which are sometimes also appropriate. In terms of some of the common toxicities that we deal with, I've listed some of the main ones there. So bortezomib or carfilzomib, the main issue is neuropathy. And this is often the rate-limiting step in how much someone can have treatment. And it's an issue when we come to second line, because if people are already have significant neuropathy, it's very difficult to administer bortezomib again. And it's a problem because then we can't use daratumumab, so it requires a little bit of fiddling of the dose and everything else, which may not be ideal for that particular patient. Lenalidomide and pomalidomide both cause myelosuppression. Lenalidomide is also associated with a significant rate of diarrhea. This can happen even after people have been on it for a long time. It seems to be related to something to do with bile salt circulation and bile salt irritation of the gut, and cholestyramine can ameliorate some of those symptoms. So that can be, we do use that sometimes. It doesn't always work, but it can help. And the dexamethasone, like any steroid, and particularly given we're using relatively high doses, can cause mood, sleep disturbance, make blood sugar worse, cause myopathy and osteoporosis. Selinexor, as I mentioned, very difficult, causes a lot of nausea and CNS side effects. So that is a bit more challenging. And carfilzomib, while it has some neuropathy, it also has some cardiorespiratory toxicity and has a higher rate of causing shortness of breath. So I usually check people for their for their cardiac function before we do that, and probably would avoid it in someone who's got significant airways disease. So one of the issues in Australia is because we can't get whatever we want when we want it, it's a bit of what can I get now for this patient? And if I do this, what can't I get later? So at the moment, second line anywhere in Australia, outside of a clinical trial, people get daratumumab, bortezomib, dex, mainly because you'll never get access to daratumumab again on the PBS. The drug's relatively expensive, and because all these subsequent clinical trials and things like that require daratumumab exposure, we're sort of a little bit constrained by that. And then we think about what's next in the next line of therapy, and how do I get to the next line, which may or may not be better, but it just requires a certain level of planning and thinking about what comes next. This is particularly the case for the transplant ineligible group, because our options get narrow a bit faster in that group. So outside the PBS, there's a bispecific antibody called elrantamab, which has just become available for through a compassionate access program. This is for people who've had 3 lines of therapy already. As I mentioned, the daratumumab, lenalidomide, dexamethasone has a positive recommendation, I believe. So it's got a patient familiarization program which has started. In terms of clinical trials, we have the CAR T therapy, which have a BCMA target. So there's 2 there, ciltacabtagene and idacabtagene. The cilta-cel product seems to be a little bit better from my understanding of the literature. So that's on a series of studies called Cartitude, and some of these studies are enrolling in Australia at the moment. And then there are 2 other bispecific antibodies called talquetamab and teclistamab, which are available in the clinical trial setting again. So these are some of the publications. I don't know if you can see that, but so we got bortezomib here in 2003 when it was first FDA approved. 2023, we're looking at teclistamab and talquetamab being approved. These are where different drugs work. The ones in the green boxes are things that we've got access to. So bortezomib, carfilzomib, daratumumab, thalidomide, lenalidomide, pomalidomide, and selinexor. Venetoclax is available in Australia, but not PBS funded for myeloma. Elrantamab is compassionate access. And belantamab is only available on a clinical trial setting. And I don't think there are any clinical trials running at the moment with regards to that. So again, this is the list of various drugs that have been approved and the timelines in which they've been approved. Now we compare that to and this is another way of looking at it, the various eras of myeloma therapy. So way back, I didn't know this, but apparently rhubarb, orange peel, and was one combination, and steel and quinine was another combination. I don't know if that did anything for myeloma. Then we had the era of escalating chemotherapy, which culminated in high-dose melphalan and autologous stem cell transplant, before going on to proteasome inhibitors, IMiDs, and another one. Can't quite see it. Yeah, oops, might see that picture. But these are the other drugs that have been approved in the relapse refractory setting in Australia. So we're lagging behind. So thalidomide, which has been around for donkey's years, we could only use in 2006 in the relapse setting. Bortezomib, which on that previous approval was available in 2003, not until 2007. And daratumumab, we've only had access since 2021. So we are quite far behind in terms of when the approvals are. And it's even worse in the first line setting. So we look at the first line setting, thalidomide available in 2009, bortezomib in 2012. You can see here bortezomib first 2003. Lenalidomide maintenance after a stem cell transplant. 2 pivotal studies were published in 2012. We could only use thalidomide maintenance, which we never did because it made everyone unable to walk from neuropathy. We've only had lenalidomide maintenance available since 2020. Triplet therapy considered standard of care 2015 or thereabouts. We've only had access to triplet therapy since June 2020. And when we've had access to that, everyone else has moved on to the quadruplet. So it makes life a bit challenging for us in terms of getting the best treatment. I appreciate the costs of the treatment, but it's probably not best practice worldwide. Just a couple of cases of how myeloma can present and the difficulties in knowing what to do with these people. So first, it's a 56-year-old male who was referred to our clinic with mild neutropenia, which going back through his records had been there for about 6 years. He didn't have any particular findings of concern when we saw him. There was no bone pain, bone tenderness, or any real symptoms. He wasn't really sure why he'd been sent along. But we did find, as part of the workup for the neuropathy, for the neutropenia, an IgA paraprotein of about 18 grams per litre. At that stage, that was close to the 20 mark. So I decided to do a bone marrow biopsy, and he came up with 12% plasma cells. So he fit into the category of monoclonal gammopathy of uncertain significance. At the time when I did that, we didn't have access to a lot of the molecular genetic markers that we do now, but we decided to monitor him. So we ended up monitoring him for a total of 14 years before he eventually progressed to symptomatic myeloma with anemia. And we were able to enroll him into a CAR T study at Royal Prince Alfred Hospital. And he was actually randomized to a CAR T, to the CAR T product rather than a standard stem cell transplant. I've not seen him since he went for the CAR T. I think he's doing okay from what I can tell. But yep, that's one. But again, it shows that there can be a very long time before the myeloma presents. Second case, at the time, 72-year-old lady who had returned from an overseas holiday. She noted that during the holiday, she was becoming more tired and more fatigued, and she thought it was just being away from home. So she went and saw her GP and was found to have new onset of anemia and acute kidney injury. So she was sent into hospital. We found that she had a kappa light chain of 84,000, our upper limit being 20. She's still my highest that I've seen. We did a bone marrow biopsy, which showed 40% plasma cells at the time. This was after we'd pulsed her with dexamethasone to try and improve the renal function. And she also had markers for high-risk disease with a translocation of chromosome 14/16, loss of chromosome, I think it was meant to be chromosome 13, and loss of the TP53 marker. So she went on to have triplet therapy with VCD. Now, this was in 2016. At that stage, given her age and other things, we decided not to transplant her. If I have VRD today and lenalidomide maintenance afterwards, I probably would have transplanted her in 2016 if I had access to that. In 2018, she progressed, and I was able to get her onto a clinical trial that we had running at the time using venetoclax and daratumumab, and she did quite well with that. She went into remission again, but progressed a couple of years later and was on lenalidomide and dexamethasone. Again, got a couple of years before she progressed and went on to pomalidomide, bortezomib, and dex. Now, this is sort of the pattern you'd expect for someone with high-risk disease with a high-risk karyotype, even though she got probably better than average treatment in 2018 with what we had access to. And then in November of 23, she'd progressed on the pomalidomide strategy. So she got enrolled on a clinical trial using a BCMA bispecific antibody, and she's achieved a stringent complete remission, which is amazing. She continues on therapy at age 80. However, the cost of the therapy has been with the bispecific antibody. She's quite hypogammaglobulinemic, needing IVIG support, and she has some features of bronchiectasis and recurrent chest infections, which is not terrible for her in terms of needing to come into hospital for IV antibiotics, but irritating because she has lots of cough, which does affect her quality of life to some extent. In terms of the outlook for myeloma, there are two studies which I just want to talk about briefly, PASEAS and CAFEAS, which are using the quadruplets that are of drugs that are available in Australia. You've got daratumumab, bortezomib, lenalidomide, and dex. And these two studies were done in both the transplant eligible for PASEAS and transplant ineligible for CAFEAS. The standard of care arm, which is VRD, is what's considered the current standard first-line therapy in Australia. So Perseus used DVRD versus VRD. So there was the initial induction, which was 4 cycles, a transplant, 2 cycles of consolidation, and then maintenance with either lenalidomide or daratumumab lenalidomide. And they used a minimal residual disease strategy to determine when certain drugs could stop. And if MRD positivity recurred, the daratumumab was reinitiated. Now, they've used some statistical analyses here. So obviously we don't have the full follow-up data. But on their statistical analysis, the median progression-free survival, so the time when these people will have symptomatic myeloma again that needs to be treated, using this strategy for DVRD is predicted to be 17 years. The standard of care, which is what we use in Australia, is only 7 years. So I'm hoping that with this data, we will be able to move to quadruplet therapy some stage sooner rather than later, because I think with this strategy, particularly for patients maybe in their 70s, we might be looking at a therapy that for all intents and purposes is curative for them, or for at least half of them. Cafeus used the same strategy, but without a transplant. And in this study, at a median follow-up progression-free survival of at 60 months was 68% versus 50%. And this group also included people who had a transplant deferred. So if we look at just the group who were transplant ineligible, the difference was 69 versus 48%. So again, it shows the benefit of the quadruplet therapy with a significant improvement in progression-free survival. I'm just going on to immunotherapy. So the way I see the best way to explain immunotherapy is that when a malignancy is developed, a number of things have gone wrong. One of the things that has gone wrong is that the immune response has failed and the malignant cell is able to evade the immune response. Now, this may be because it camouflages itself, or it alters the tumor microenvironment, or it suppresses the immune response mounted against it. The first type of immunotherapy that we really used was allogeneic stem cell transplant. So in this case, what we're doing is we're transplanting a donor-donor system into the recipient. And we're relying on the graft versus tumor effect to get rid of any myeloma, any tumor that is there. Unfortunately, it's not predictable whether someone is going to have a graft versus tumor effect or not. We're dependent on the donor. Not everyone has a donor. It's only a 25% chance that a sibling is a donor. So it's a little bit hit and miss whether we're going to get a graft versus tumor effect. Similarly, the cost of this is graft versus host disease, which can be debilitating and in some cases life-threatening. Some tumors are more immunogenic, so allogeneic transplants have worked historically better for some conditions than others, and it's best when there's a low tumor burden present. For a range of reasons, never really used widely for myeloma. For some reason, patients with myeloma seem to have a higher rate of toxicity relating to the transplant, and so it's never really been widely adopted in the myeloma setting. Again, the other group of drugs are called immune checkpoint inhibitors. Not really had a role, as far as I can see, in myeloma. Now, these drugs enhance the T cell response, and again, the issue is they try and overcome tumor camouflage. So the immune system recognizes self and non-self. Tumor cells, which originated as self, should be recognized as non-self, but they're not being recognized. So the PD-1, PDL drugs try to disrupt that and get these tumors recognized as non-self. However, that does come with issues, as you can get significant autoimmune complications from these drugs, so that needs to be watched out for. Now, these are some of the different bispecific antibodies and CAR T cell products that are used. Now, in simple terms, the bispecific antibodies are off-the-shelf products, and what they try to do is bring the T cell and the tumor in a close proximity to each other so that the T cell can then kill the tumor cell. Advantage is an off-the-shelf product ready to go. The other strategy is the CAR T cell. Now, this needs to be constructed from the patient cells. The cells have to be collected, sent away for manufacture, and then brought back. In this case, the T cells have been engineered to recognize the tumor so that they will hopefully then kill off the tumor cell. And hopefully some of these T cells will be persistent and hang around, and so be able to continue immune surveillance for a longer time. The one in the bottom corner here, the ADC, is when we have an antibody drug conjugate. So the drug belantamab does this where it has a toxic payload that's bound to a antibody to deliver to in a targeted way. So bispecific antibodies, as I said, they try and link the T cell with the antigen expressing cells and cause T cell mediated cytotoxicity. Any target cells that express the antigen will be affected. It's an off-the-shelf product. In the terms of the myeloma bispecifics, when we administer them, there is a risk of what's called cytokine release and neurotoxicity. That's largely manageable with dose escalation therapies, but they cause significant plasma cell depletion of normal plasma cells, causing hypogammaglobulinemia with an increased infection risk. This is a schematic of a CAR T cell construct. So what happens is this is induced into the T cell with a viral vector and gets expressed, and it's got a number of domains. So this is the bit that binds the tumor. Then here we have a couple of modules that stimulate the T cell to kill and just stimulate the T cell to proliferate. The whole range of publications and data about different types of CAR T and how they work, but this is a simplified form. So the CAR T is an autologous product. It's manufactured from the patient's T cells, which have to be collected by apheresis and then sent overseas. Prior to the CAR T cells being administered, patients receive chemotherapy with some form of immunosuppression. What's called the vein-to-vein time is about 4 weeks. So about 4 weeks from when we collect these T cells to when they can be reinfused. It's getting a bit shorter, but Australia is far from everywhere else, so it takes a while to get the cells usually to the United States and back again. Currently, there are no commercially funded CAR Ts for myeloma. CAR Ts are not free. The problems are you have acute toxicity. So there are a couple of things. There's cytokine release, what's called immune effector cell associated neurotoxicity and hemophagocytic syndrome. All of these things can occur. They can be quite serious. They can be life-threatening. There are protocols in place to manage the cytokine release and HLH. Immune effector cell neurotoxicity is a bit harder. People get put on anti-seizure medications and other things, but sometimes you just have to wait and see. Longer term, there are issues with cytopenia and increased risks of infection. There have been some rare cases where T-cell lymphomas have arisen from the CAR T construct. It's exceedingly rare, but it has resulted in a black box warning mandated by the FDA for CAR T-cell products. That's one of the things which people need to be consented about. It's very rare, but it has happened and it is recognized. So when do we use the CAR T? So assuming I could access it, initial studies were for people after multiple lines of therapy, and it showed significant improvement in the progression-free survival for people who otherwise had an abysmal prognosis and were likely to die within months. There seems to be a plateau in that curve, so possibly some of these people have been cured. Looking at the tumor biology and evolution of myeloma biology, it would appear that it makes sense to move the CAR T to earlier lines of therapy. You have a fitter patient, you have a better immune system that's been less beat up by chemotherapy and other drugs, and possibly the myeloma has been subject to less selection pressure. So maybe the tumor is a bit more sensitive in that setting. So this is where some of the studies are. The current study that we were waiting for is what's called CARTITUDE-6, which that first patient of mine was referred to. So they get quadruplet therapy, which again is fantastic. They get randomized then to either a stem cell transplant or the CAR-T product. So I think this study is pretty close to finishing recruitment. And I guess we're all waiting to see what that shows. If it shows this is better than Dara VRD and Perseus, then yeah, we might change how we're managing myeloma. That being said, CAR-T therapy is very expensive because each product has to be manufactured for an individual patient. Finally, as I mentioned, we do use clinical trials a lot. This is the clinical trial refer app when the website is there, and you can search it for basically any clinical trial in any field, really. So there are studies, you just click through, choose Australia and the area of interest. It's not perfect because it relies on people at different sites keeping their data up to date, but it does give you a feel for what's available, and you can always contact people and say, is your trial still running, recruiting? If not, is there something else available? And I'll stop there if there are any questions.
Thanks very much, Sundra. So there's 3 questions so far, and I'd encourage people to add your questions while we're talking. The first one is indolent myeloma an old terminology, and what does it correlate to these days?
Yeah, so indolent probably is smouldering myeloma. It's not a term we use really much anymore. So the problem with smouldering myeloma is there are some people who are going to sit like that for a decade and not do anything. Then there are other people who you think are at high risk and they're going to develop renal failure or a fracture or something in the foreseeable future. And those are the ones you want to treat before something, you want to treat them before the car goes over the cliff. The problem is we do not have a good predictor of the ones in smouldering myeloma who are going to do badly, the bad players. At the European meeting that I was talking about, there's a lot of discussion about this. But the problem is there are a number of models to try to assess this, but none of them, they're not concordant with each other. So that makes it very difficult. So ultimately it comes down to a question of looking at the person in front of you, looking at their parameters and trying to work out, based on the treatment options that I've got today, what should I do? So I've got a guy who's 45. He's got a high paraprotein. I've done his bone marrow. He doesn't have any CRAB criteria. I haven't been able to get an MRI for him as yet because it's expensive, but I might look at doing a different version of that. But at 45, as things stand at the moment, if I commit him to treatment, he needs an autologous stem cell transplant. So we're talking about very hefty therapy. So that's where it gets a bit tricky. If this guy was 75, it's a lot easier because I'm not going to give you an autologous stem cell transplant based on your age. But if I start you with the chemotherapy, maybe I've started you 12 months, 18 months earlier than you needed to be, but hopefully you won't run into any problems with a fracture or something else at that point in time. So that's a discussion. So the guy sent for an MRI recently. He's 70. Should I do a transplant on him? If I can get him onto the clinical trial with some new drugs, that would be better. But yeah, so it's a discussion with the patient. So that's why it's difficult. But there are some smouldering myelomas who will sit there and not do anything for a long time.
It's always difficult when there's lots of options and none of them is the clear one.
Yeah.
Yeah. So someone else has asked, given the evidence that FMT helps in treatment with PD-1 inhibitors, Are there any studies with FMT with regard to myeloma?
I'm not sure what do you mean by
I'm
FMT?
wondering, I'm just going to ask the person who posted that, do you mean fecal microbial transplant? So I'm going to give them a chance
Yeah,
to answer that and
yeah.
clarify the acronym. So we'll go on to the next one. Oh,
Yeah.
and that is just a comment. Given the complexity of information, it would be helpful to have the slides for reference.
Yeah.
So
That's fine.
be able to sort that out. So they're the only questions I've got so far. Yes, FMT equals fecal microbial transplant. So
Yep.
re-ask the question, given
Yeah.
the evidence that fecal microbial transplant helps in treatment with PD-1 inhibitors, are there any studies with it with regard to myeloma?
Not that I'm aware of. No,
Mm.
I couldn't say that. I don't know. Yeah.
It's an interesting question because
Yeah.
we had a lecture very recently from a gastroenterologist who's interested in the microbiome at St George Hospital. So
Yeah.
we're all just a little more curious about how
Yes.
that's
Yeah.
going to impact stuff.
Well, look, I mean, what was it? I went to a meeting a long time ago, and it was shown that if you had a particular set of fecal microbiome, you did better in the allogeneic stem cell transplant. That's never been translated into anything else, but it was an observation. It does show that it's important. And it may have some implications for, when people are sick and getting them to a transplant, the amount of antibiotics they've had prior might not be ideal in some cases. So
And of course, they all get antibiotics as
they
part of their
all
supportive treatment.
they all get a fever and they all end up in hospital.
Yeah. Well, we've come to the end of the time. So, sorry, there's one more question and it looks important. Neutropenia is a common finding in patients, and some of them confirm to have cyclic neutropenia.
Yep.
If they have normal immunoglobulins, do we need to monitor them? Can I just give a plug for Health Pathways? Because we've got a health pathway on neutropenia, so which is quite helpful for working out who needs to be referred. But then I'll let you answer it, Sundra.
Yeah, look, neutropenia is complicated for a couple of reasons. One of the things is that there's a pre-analytical problem. So a lot of people are having their blood count done at a private pathology collector. It takes a while before it gets sent to the lab. Now, if your neutrophil count's 2.5, which is in the normal range, and it drops by 0.5 while it's sitting in the tube for 6 hours before it gets processed, it then drops out of the normal range, and then people say, oh, this is mild neutropenia. So often we send people straight to the lab and it's run straight away. We say, okay, the neutrophil count's. So that's one problem that we have with neutropenia. Cyclic neutropenia is relatively rare, relatively uncommon. There is a gene test that we can do to look for it. It's not funded, but it can be done. Simplest way is probably to do a full blood count once a week for 6 to 12 weeks and see if there's a pattern of neutropenia that then resolves, particularly if at that time people have coexisting things like mouth ulcers and stuff like that. When they're neutropenia, that fits a little bit more. And then the final thing is people who are of North African Mediterranean background. There's a phenotype called the Duffy null phenotype. So this is people who don't express the Duffy antigen on their red cells. And for reasons which I don't know, this group of people tend to have lower neutrophil count. They don't run into problems with infections or anything else, but it's one of the things that we look at when we're talking to people about, and we say, if there's any particularly Egyptians and places like that, there seems to be a higher rate of the Duffy null phenotype. And so that's one of the things we also ask about. So that's sort of the basic easy stuff. And then, you have to look at the film, see, is the hemoglobin low, is the platelet low? Are there any other things going on? And, sometimes, yes, you do find that someone's got myeloma or lymphoma or something lurking there that's caused the problem.
All right. Thank you so much. We have now reached the end of our time, so I will close it now. Thank you for the questions, everybody, and for your attention to the talk. Thanks very much for the work you put into the talk, Sundra.
No worries.
And thanks, Bertha, to the PHN for hosting So we look forward to seeing you all next month. And I think the talk is from rheumatology, and it's Alan Sturgis on back pain. And please remember to fill in the feedback form that will come up when we close the meeting. Good night, everybody.
Okay. Thank you, everyone. See you.